Thank you, sir. Going back to the basics, prevention of infection in open fractures, the consensus view. Now, these are the key principles that have to be followed meticulously in order to try and prevent infections. Point number one, have a complete evaluation of all high-energy open fractures. Follow the ATLS protocol, look for and manage life-threatening injuries. Document the neurovascular status. As soon as possible, initiate systemic antibiotics and, if required, tetanus prophylaxis. It is always a smart move to take clinical photographs of open injuries, documenting the size, location, and contamination, and then proceed for generous emergent irrigation of the wound. Cover the wounds with a sterile compressive dressing. Gently apply pressure to realign the fracture and splint the limb. Do not take cultures in the emergency room. They are of no clinical or substantial value. Be always cognizant of the fact that compartment syndrome can also occur in the presence of open injuries due to severe crushing symptoms, and failure to recognize these can have disastrous consequences. The most widely used classifications are naturally the Gustello-Anderson's and its variations, and our own Ganga classification. Now, the Gustello's classification is naturally based on the size of the wound, but it does not take into account the soft tissue status and the contamination. It corresponds well with grading and the infection rates and the fracture healing times, however, has high degree of subjectivity, and studies have shown low inter-observer agreement. Therefore, it is recommended that your classification not be done in the ER, but after primary wound care and debridement in the OT. Now, that brings me to the Ganga Severity Score, which classifies injuries on the basis of 4 major criteria. It not only helps in the assessment of the severity of injury, but also provides you with guidelines on reconstruction. Point number 2, systemic antibiotics. Early systemic antibiotic administration is the key to success. This has been proven by a number of studies that looked at this variable. A delay of more than 3 hours is associated with increased risk of infection, irrespective of the timing of surgery. Most acute infections are caused by pathogens that are acquired in the hospital, especially wounds that are left open for longer durations. Currently, the most open fracture infections are caused by gram-negative rod bacteremia and gram-positive staphylococcus. Only 18% of infections were caused by the same organism that was initially isolated, whereas 92% were caused by organisms that were acquired in the hospital. This enumerates 2 points. First, it dissuades you from going in for early cultures, and secondly, advises you to cover the wound as quickly as possible. In majority of open fractures, you will encounter the S brothers, the Staphylococcus and the Streptococcus. Now, studies have looked at the sensitivity and specificity of various antibiotics. They have also looked at the negative impact on fracture healing and inhibition of osteoblastic activity. And it is more important than the type of antibiotic is initiation of prompt treatment. Although there is no major consensus, majority of studies agree that in grade 3 fractures, we need both gram-positive and gram-negative coverage. Another quick question that needs answering: for how long should the antibiotics be continued? Well, studies have proven that there is no difference between 1 to 5 days of post-operative antibiotic therapy. Point number 3, primary surgery and debridement. The key to your primary surgery should be preservation of the life and the limb, accurate and complete debridement, initial injury assessment, and fracture stabilization. Now, for long we have worked under the assumed 6-hour rule. This had been the basis of our treatment of open fractures, but current literature has debunked this. And currently we know that there is no significant difference between before or after 6 hours of injury. Now, with the exception of low-grade gunshot wounds, all open fractures require debridement. And the principle of debridement would be all devitalized and contaminated tissue should be excised and all devitalized bone fragments removed. In case of gross contamination, you may require serial debridements. Remember, in such a scenario, then an additional 3-day antibiotic therapy should be given for every repeat debridement or wound closure. Now, with regards to debridement, timing to the OR is probably less important than the adequacy of debridement and the time to soft tissue coverage. Therefore, debridement is not emergent that it should be done within 6 hours, but is urgent and should be done within 24 hours. The places where this rule does not apply would be if you have a patient with neurovascular compromise, compartment syndrome, or gross contamination. The solution to pollution is naturally dilution, and therefore, depending on the severity of contamination, ideally use 6 to 10 liters of saline. What is the role of pulsatile lavage? Studies have shown that although it has better bone cleaning, but it has actually less wound soft tissue cleaning, and it even inhibits bone healing and is not therefore recommended. Should we be mixing antibiotics in the irrigation fluid? No conclusive studies have proven, and therefore no proven benefits. Should we be using soaps with irrigation? Now, soaps emulsify and remove debris, so it can be helpful for reducing gross contamination, but have no significance with regards to decreasing the infection rate. So the level 4 based key recommendations are therefore that in the first washout of highly contaminated wounds, use soap solution, then redrape the patient and repeat washouts with saline. And in infected wounds, use soap followed by antibiotic solution. Point number 4, local antibiotics. Local antibiotics provide high antibiotic concentration, and because they're heat stable, they can be active against suspected pathogens. And they decrease the overall infection rate, and therefore the basis of their usage with cements and nails. Point number 5, wound closure. Wound closure for contaminated wounds is controversial. For long, we thought that open wounds should be left open for longer durations to facilitate drainage. This is now proven wrong. Shakespeare was unable to answer, to be, not to be. But science has now answered, to close or not to close. Recommendation, primary closure is recommended. Contraindications to primary closure would be inadequate debridement, or if there is a delay in institution of antibiotics or treatment. And when you do primarily close these wounds, there is shown to be decreased infection rates. Vacuum-assisted closure is also recommended, for it reduces edema and improves microcirculation. Point number 6, fracture stabilization. Type 1 injuries, no specific difference required. But type 2 and type 3, we have to try and stabilize the fractures so as to reduce the dead space, reduce the inflammation, and improve tissue revascularization. So the key to your final success would be a principle-based detailed evaluation. Initiate antibiotics and initial presentation as soon as possible. Do a thorough surgical debridement in the OT. Accurate assessment. And finally, closure and stabilization depending on the soft tissue patterns and tissue. Remember, the measure of intelligence is your ability to change and adapt as per the scenario faced. Thank you.